All right, so welcome, Dr. Haylee Borgstrom. She's joining us today to talk about all things elbow, and we might touch a little bit on shoulder and wrist a little bit. But thanks so much for joining us, Haylee, for an episode here on Hooked on Health.
Absolutely, I'm so happy to be here, Sean. Thanks so much for having me today.
Yeah, so let's just tell the audience a little bit about your path to becoming a sports medicine physician, and a little bit about your passions and who is your perfect patient.
Yeah, absolutely. So I think similar to a lot of us in the sports medicine field, I think my own injuries, playing sports growing up and playing basketball through college really kind of put me on this path. I went to medical school because I was very interested in orthopedic surgery. I had unfortunately had to have a couple shoulders and a knee, an ACL, like many women basketball players have. And so that's what initially, got me interested in going to medical school. I had, a background in exercise physiology and biomechanics in terms of kind of my undergraduate and postgraduate training. So it was kind of a natural fit. And as I got into medical school, I started to explore different routes. I found the field of PM&R, or physical medicine and rehabilitation, which is a non-operative field and is very, is kind of a smaller field, but allows very kind of broad opportunities, really treats kind of any impairment or disability, as small as a rolled ankle, a sports, kind of sports injury, to brain injuries, spinal cord injuries, et cetera. And from there, I came out here to Boston to do my residency here at Spalding and Harvard. And then I stayed on and did my sports medicine fellowship here at Spalding and, with a lot of the Mass General providers here. And I stayed on. I'm originally from California, both my husband and I. So it's saying something, I think, that we're here. We decided to suffer through the winters just for the quality of medical care that's available here, the patients, that I have the pleasure of taking care of on a daily basis, and just the resources and the mentorship. And, it's a wonderful program to be a part of. So that's just a little bit about me, kind of my path to medicine. Couldn't be happier, where I landed in terms of non-operative sports medicine, and really trying to incorporate both clinical practice as well as, the research side of things, trying to advance what we know and how we treat patients in an evidence-based way. So
that's great. That's great. So tell us a little bit about, I think when people think of sports medicine physician, a lot of people's minds go straight to surgery, right?
Sure.
So, even my mind too. And I think the PM, the physical medicine field is sort of really emerging as a juggernaut in, kind of clinically honing down on the cases that don't need to be operated on. Talk to the audience a little bit about how you work hand in hand with orthopedic surgery and with like PT, OT, whatever, to get the best results.
Yeah, that's a great question. One of the things that I love about my field and my training is that I'm so used to working in, a multidisciplinary team kind of approach to medicine. It fits me and my personality well. I think just growing up playing team sports and loving that type of environment. And so it's an easy transition for me, kind of onto the other side of things, not as the athlete anymore, but as the provider. And like I was touching on a little bit earlier, we just have such a supportive and integrated and multidisciplinary team really here in sports medicine, where every day, I'm in the same office as our orthopedic surgeons. So I know them well, they know us and myself well. I know what their special interests are, what their areas of strength are, and they know mine. So it helps, in terms of directing patients to the right person in a more individualized way. And then right across the hall from us here are sports physical therapists. We have really, with the leadership of Miho Tanaka, one of our orthopedic surgeons, Kelly McGinnis, another one of our the PM&R sports medicine providers, they've really started to develop a women's sports medicine program here that really integrates other areas of medicine. So endocrinology, thinking about the mental health piece and the psychology piece, dietary pieces, all this, so it's just it's fun to work as part of a team. And I think honestly that it just creates a better experience for the patient when everyone's on the same page and you have multiple people thinking about the patient in different ways.
Yeah, with different specialties, and I think
Yeah,
I mean, that's truly a patient-centric model of care. And I think
absolutely.
that's
And
where
that's what we aim for. Yep.
that's great. Let's talk about you specifically, and what is your niche? Like, if you were to carve out something that you love to see, obviously you're a basketball player, but
Yeah.
and you had an ACL yourself. Like,
Yeah.
who's your, like, what do you, I mean, obviously you can treat anything, I'm sure, but what do you love?
Yeah. And I always struggle with that because I love the variety that I'm able to see. A lot of our surgeons are so brilliant and wonderful, and they specialize in maybe one or two joints, or maybe more than that, but they really focus in. It's a hyper special, medicine has become kind of hyper specialized. And one of the things I love about my job and my kind of area of practice is that I really can keep it diverse and broad, but I'm working on kind of expanding the basketball piece, and really trying to reach out to kind of more athletes with those specific types of injuries. I think it's great and important when your provider knows a lot about your sport, and I'm always trying to learn more, about new sports and the biomechanics, and the specific injury risks that affect rehabilitation, et cetera. But yeah, I'm trying to work on that basketball piece. And then I love the knee. We're here today to talk about the elbow. I love the elbow. I see a ton of it. I see a ton of hip. I see all joints. But I think within the sports medicine world, especially with the research, in my kind of special interest research piece, I am interested in kind of female athletes and any, specific needs, that they may have. That may be unmet, in certain other clinics or areas of medicine. I'm interested in adaptive athletes, adaptive sport athletes, athletes with disabilities, and kind of, trying to make sport and exercise accessible for everyone. And then, I'm developing a special interest in Shockwave, and, we may talk a little bit about that, later in the podcast, but, trying to kind of expand the role that can play, in addition to a lot of the other regenerative, injection options that we offer for patients that just aren't getting better with kind of our standard of care medical treatment.
Yeah, so we're definitely going to do a deep dive into that later.
Great.
We work with a podiatry group, actually, that's close to us, Central Mass, and actually Dr. Savia joined us a couple of months ago, and they do Shockwave with great success to the Achilles, plantar fascia.
Yeah.
But, there are certain like shoulder calcific tendonitis and tendinopathies, elbow, right? So things.
Yeah, lateral elbow, probably definitely one of the strongest areas of literature supporting the use of, Shockwave, as well as PRP and other kind of orthobiologic types of injections. But yeah, awesome applications in the foot and ankle. Just really love the option, especially for people who are trying to stay active through their treatment. Whereas some of the other injection options require a little bit more of downtime. So it's kind of cool, for people that are either in training, that are, that again, just want to stay active, maybe they're in season. So it's just another, I think, tool, in our tool belt that we should be able to offer, people when appropriate, of course.
Yeah, absolutely. I think that's great. And then you touched on the female athlete piece. I mean, it really is almost like treating a totally different population. I think, so we have 2 women's health specialists here, and the specialty here kind of focuses more on pelvic floor.
Yeah.
But you're talking about a women's rehab program, or especially the teenage female athlete.
Absolutely. The adolescent
totally
athlete. Yeah.
Yeah. Totally different monster than,
Yeah.
than other we see. And I think just having that understanding as a provider is so important. And it's unbelievable that the struggles and the different, challenges that young females have versus young males.
Yeah, 100%.
We all know the ACL rates and things like that.
Yeah,
but,
absolutely.
We might, and I think we're going to touch on joint laxity a little bit too, especially with the gymnasts, the performing athletes, elbow dislocations, things like that. But I just, I think it's really cool that you have a really, an interest in that. And
thank you. Yeah, it's really exciting.
And then people should know that, there are specialists that work with, young adolescent female athletes, and not just.
Yeah, absolutely. Bring them my way. I'm always happy to try to help coordinate that care and think about just the whole person, because like you said, there are unique aspects to a female or a woman that are unique to them, whether it's, specific anatomic differences, biomechanical differences, the way that we recruit muscle and turn it on and turn it off. And then of course, kind of the hormonal piece. So all just so important to keep in mind. It's just, again, like you said, that patient-centered, individualized approach.
And it's a holistic model too. It's not just driving straight toward a PRP injection or,
exactly.
You've got consultants from every different specialty field, which is great.
Exactly.
Cool. So let's do a deep dive right into the elbow. What do you think?
Do it.
Awesome. So talk to me about the common, elbow injuries that you typically treat. We've got a bunch of golfers, and usually this is like golf season. The golfers come in March.
Oh, I know. It's on the rise.
They want the programs. So talk to me about, let's just cover the common elbow conditions you typically see, and then we'll maybe do a little dive into golf.
Yeah, I would say probably the most common, and we'll you mentioned kind of golfer's elbow, tennis elbow, and it's a little bit of a misnomer, and I know that that's something we're going to touch on today as well. But golfers get tennis elbow, and tennis players get golfer's elbow. It's just based on kind of biomechanics, and it's not always sport related. There's a lot that we do that's repetitive in our day-to-day lives that that maybe predispose a person to one or the other, the inside or the outside of the elbow. And so really, I don't even use those terms. I try not to use those terms in my clinic because again, I think there's a little bit of a misnomer there. I would say the most common elbow diagnosis that I see and I treat in my clinic is lateral elbow epicondylosis, epicondylitis, and or tennis elbow, kind of colloquially. So by far, that's the most common elbow condition that I treat in my clinic. I'd say in terms of medial or the inside of the elbow epicondylosis or epicondylitis, much less frequently, though certainly not uncommon. I'd say probably for maybe every 10 or so lateral elbow pain, I see maybe one, maybe two medial elbow. And those are the two most common diagnoses. Other things that I see, are elbow arthritis, other tendon issues in the area. So, especially in throwing athletes, triceps tendinopathy or tendinitis, distal biceps in the front of the elbow, tendinitis or tendinopathy. And then as you get into, like you mentioned before, gymnasts or weight-bearing athletes, I think about bone stress injuries, stress fractures. And of course, depending on the age of the athlete, you're either thinking more about the bone or the soft tissues, and our more skeletally mature athletes, oftentimes it's the soft tissues, the muscles, the tendons, the ligaments, the UCL in our throwers. And in the younger athletes, a lot of times it's those growth plates. Similar mechanisms, but those are all the types of kind of overuse injuries that I see. And it's really a mixed bag. I like I said, I like to see a lot, and I do get to see a lot.
And do you get to see much trauma, or is it mostly overuse?
Yeah, so most of the trauma that I see is kind of sideline type trauma. So if I'm covering, a football game or a hockey game or something, something like that, usually collision sport, that's where I see the trauma. Otherwise, trauma is usually filtered kind of through other channels. Since this is, I'm primarily practicing in an outpatient-based setting, most of the trauma goes, to the emergency room or through the kind of urgent care clinics and that way. So I do end up seeing a lot of kind of sequelae or kind of post-traumatic issues that people are still dealing with after a trauma, say an elbow dislocation or, something like that, fracture. But it's lower acuity unless I'm covering at the sideline usually.
Sure. Yeah. So like contracture or something like that.
Yeah, absolutely. Or chronic pain. You know, a lot of times when people have dislocations or fractures, you know, they have a period of immobility and they struggle kind of getting range of motion and strength back, and, you know, have chronic issues with pain, you know, at least in the kind of post acute phase. Potential nerve involvement, you know, things like that. So I'm treating kind of the downstream effects usually of the traumas, but you know, I do. People end up sneaking through every now and then that had falls, and you know, and we diagnose fractures and things like that as well. So keeps me on my toes.
Looking for that stress fracture, right?
That's right.
Or that avulsion. So let's talk about, you know, and I think we talked about this a little bit in the shoulder piece too, you know, and just let's talk about the epicondylgia, right? And the difference between an osis and an itis, and really the tendon changes. Because, you know, I think let's get a little nitty gritty here so people understand why we're doing non-operative treatment. Because the biggest complaint that I get in here, not necessarily complaint, but, you know, people come in, my elbow hurts. And usually it's an osis, right? It's a tenocyte death type situation where there's chronic changes to the tissue. And you and I both know the research. It's so tough to fix that lateral elbow joint, you know, unless you're injecting, you're getting some platelet-rich plasma in there, you're doing the shockwave, you're doing the dry needling, you're doing something to infarct that tissue to then grow, you know, get some blood flow there. Yeah. So talk to our audience a little bit about, you know, what it means to have a tendinopathy or an osis, and when it goes on for a long period of time, what are their options to treat it other than surgery, obviously? Really,
really, really great point. And I have this conversation every single day in my clinic, at least once a day. And I think it's so important for patients to understand, you know, the difference between the itis and the osis or the opathy, because like you said, it does change the way we think about treating it. And I think that the more patients can understand about the underlying issue, you know, the more they can kind of be empowered to take control of their own care and make sure that they're, you know, finding a treatment plan that really works for them. So in terms of the itis, everyone knows tendinitis. The term tendinitis is used a lot of times when it's not even appropriate necessarily. The way I think about it is itis is an inflammation. It's usually an acute phase, something that's been going on for a very short period of time. And there really is that kind of inflammatory response. The tendon is inflamed, you know, the cells that are drawn to the area are those inflammatory mediators, and pain, you know, cytokines, it just, you know, there's a cytokine influx, there's just, that's the inflammatory cascade. And there may or may not be, you know, kind of acute kind of partial tears to the tendons, things like that. But the overall organization of the tendon is usually intact because it's, you know, it's more of a short-term kind of inflammatory response. And that is in complete contrast to the osis or the opathy, the tendinosis or the tendinopathy, which is a chronic change, like you were mentioning. And really the primary pain generator, the reason that it hurts is not an inflammation or an itis. It's the fact that the tendon, structure of the tendon is not what it used to be. The organization of the fibers of the tendon are not organized. They become very disorganized. The quality of the cells are less than, you know, a normal cell. In addition to the disorganization, you get sprouting of abnormal blood vessels in the area, as well as abnormal nerves in the area, which can contribute to hypersensitivity and pain in and of itself. So a lot of what we're doing, I think, you know, is really is even targeting some of those abnormal nerve sprouting, you know, a lot of the kind of secondary stuff or the soft tissue work and even the strengthening, you know, the eccentric strengthening piece and things, I think are targeting all of these chronic degenerative changes that occur with the osis or the opathy picture. And if you think about, say, for example, steroid injections, which are just a potent anti-inflammatory, you know, I think that the the argument there is that why are you using an potent anti-inflammatory in the chronic phase when the primary pain generator, the primary issue is not inflammation, it's disorganization, it's poor tissue health. And that's what guides a lot of my colleagues, hesitance, amongst many other things, the side effects of steroids, things like that, in using some different types of treatment options. So I do think it's super important. Thank you for bringing up this point, of the acute phase versus the more chronic phase, and how and why we choose different treatments.
Yeah, and do you think, and this might be I always tell people, as soon as you feel something, if it's been 2 weeks, you can try to manage on your own, rub it a little bit, whatever, because people always pull me aside on the golf course. They'll say, hey, listen, right. I mean, at a party, you go to a party, go to dinner, be like, Haylee, my elbow hurts. And you're like, okay, take some ibuprofen and call me in 2 weeks. Right. So, that's usually what I say, but we want to hit this before there's chronic drastic tissue change. Right.
Absolutely.
But a lot of times it's the guys that it's like, it happens every year around the same time. They pick up the golf clubs, they start swinging again. And there comes the itis part. So I feel like sometimes you get the layers of the itis on top of the osis.
Absolutely.
It gets kind of foggy, but, to your point, they've done studies where, during that osis phase, or there's really, there's no inflammatory cells. It is not inflamed. So if you're going to hit it with a cortisone shot, it's not going to get the results that you're looking for.
Exactly. And you're still exposing the patient then to the potential downsides of the steroid, which include actually weakening of the tissue, at least transiently, and potentially increasing risk for, partial tears or even ruptures, which from a non-operative standpoint is something that, keeps me up at night. I don't want to make a patient worse. That's my whole thing. I'm supposed to be helping people to get better. And so, thinking about the risks and benefits of all these different types of, treatment options is just so important. But yeah, I mean, I completely agree with you. If it can be nipped in the bud, before it gets to that chronic phase, of course, that is the most ideal situation. And a lot of times I agree, there's the chronic underlying kind of smoldering osis. And then you get these flares, where you do have a little bit more of an acute inflammatory phase, in addition to the chronic underlying tissue disease. So again, these are all things that, I think about and I talk with patients about on a daily basis.
Yeah, no, that's great. So let's just dive in. Let's talk about the treatment options, right, for that osis, and I want you to define the person who's, best, give me that clinical case.
Yeah, absolutely.
Male, female, what do they do for activity?
Yeah.
How long they had the pain? Let's dive into that.
Yeah. So I have kind of generic or, kind of treatment algorithms in my mind, steps that I like to go through. And in general, I like to progress from least invasive to most invasive, right? To kind of most evidence-based to, more experimental or, slightly less evidence-based. And I also keep in mind out-of-pocket costs for the patient because I want to minimize those when at all possible. And so, someone comes into the office, they've had, a couple months of pain on the outside of their elbow. Of course, I go through a history, an exam, and say I think it's consistent with lateral epicondylosis. A lot of what I'm doing at that initial visit is just education, like the conversation that we've been having here today, in terms of what the diagnosis is, maybe biomechanical issues that might have predisposed them, certain activities that may have predisposed them. And then I'm initiating kind of a conservative treatment plan. And what I mean by conservative is I'm not sticking with anyone with needles. Usually, the first time I meet them.
Not how you say hello. You don't just stick them with a.
I don't do that. I mean,
Shockwave machine.
I believe in being a little more cordial. But yeah, so what that treatment plan usually looks like is getting our sports physical therapists involved early. And whether, and that also depends on kind of the patient in terms of how much time they have available to them, resources they have available to them, insurance coverage, et cetera. Because certainly there are self-directed things that patients can do to address these types of problems on their own at home as well. And I think that's, I think that's reasonable for a lot of people too. And so what that looks like is kind of the standard, RICE, right? Everyone knows that: rest, ice, compression, elevation. So rest does not mean immobilization. Rest means relative rest. The activities that are provoking your injuries are cut back or eliminated for, a short period of time as you allow the area to begin to heal. Ice, heat, other kind of modalities, soft tissue work, massage at home. Compression, thinking about, that's not like a rolled ankle where you get, usually a big effusion or something like that, and you're needing to get the swelling out of the area, but it does, it can get a little bit of swelling in the area. And using things like, braces, either, at kind of the forearm counterforce braces, and especially neutral wrist splints, especially at night, I think is absolutely necessary for kind of the initial management of these two diagnoses, both medial and lateral elbow pain. And really then is kind of like thinking about what the biomechanical issue was that predisposed the patient to get this in the first place. Because if we just treat it, and then, like you said, every spring they go back and, the weather gets nice and it just comes back. If we can't fix the underlying issue, which is usually muscle weakness, at the end of the day, muscle weakness and or, poor sport biomechanics, then it's likely going to just flare up off and on over time. And that's where I rely a lot on my, physical therapy colleagues and specialists who can create individualized plans of care, advancing from kind of the, more of the isometric type strengthening all the way through, to incorporating the eccentric training, which is really going to build the muscle strength there and allow the muscle to absorb force rather than the tendon going in and, attaching at the bone. If the muscle can absorb more force, then the tendon has to see less of it. And the tendon can kind of heal and see force in a good way, a healthy way that allows the tendon to remain healthy and kind of remodel in an appropriate way. So these are all things that, I absolutely have to be included, right? I mean, there's no skipping steps is what I tell patients a lot, because it, the work you put in is going to equal kind of the result that you get, and one size doesn't fit all, and again, that's why I just love having just such knowledgeable sports physical therapy and physical therapy colleagues, because they can really advance patients in an individualized way. And, if they have other pre-existing issues, maybe they have some arthritis in the elbow or in the wrist, maybe they have, arthritis in their neck and some, pinched nerves and things like that. And activities may need to be modified, right, to allow a patient to succeed and do them appropriately. So that's all non-negotiable, I think.
So that's a big plate for a lot of people to eat. So I think that when they hear all of that, they're like, "Whoa!" And then,
whoa, it's just my elbow hurts.
I have to do all this, and then they're searching for braces on Google and yada yada. Yeah. So let's touch. There's a couple things that I want to pick. So I mean, it's just those are all great points, right? So it's really multifaceted.
It is.
And I'd love to get your take on the compression piece, because that's kind of a hot question, right? So compression proximally over the ECRB, and RL, bodies, the proximal portion there, and then how you explain to people that it's really a wrist problem. So the pain is here, but it's really, we need to keep your wrist neutral.
Yeah.
Let's talk about that. And then the other piece too that I feel like can't go unmentioned is just the stress on the tendon, right? So addressing that muscle length, mid belly, finding the trigger points, doing the soft tissue, and really this goes throughout the body. That's something they don't really touch on really in PT school either. They say, okay, here's the stretches, here's whatever. And then you have like I went to Northeastern, they did like one lab on like massage. I'm like, what is this? So you have to, I did a ton of Con Ed just between, assisted and dry needling, anything you can do to help improve muscle length so that it's not pulling on that tendon. Right?
Exactly. Right.
So, and that's a huge piece of any tendinopathy. And it's so hard to get the patient buy-in when it kills to do the eccentrics. You think about the Achilles, you think about, the elbow. It's just the people are in so much pain, Haylee, that when you're like, okay, here's this 5-pound weight, just slowly drop it, they want to punch you in the face.
Right.
Like,
no,
okay,
I get it.
Start somewhere. So, And again, how it's tied to posture, right? So I've never seen somebody with a 5 out of 5 external rotation group come in and, you know,
Yes,
wrist
100%.
extension. So let's talk about how that all
Yeah.
comes in, and it's like 17 questions in one, Haylee.
Yeah, no, that's great though. I love it.
But the wrist, the compression piece, and what you recommend for folks for that compression, if you recommend anything, and go.
Yeah, absolutely. So I mean, you're speaking to my heart with thinking up the chain and thinking down the chain, right? So when we're kids, we all sing the song, the neck bone's connected to the shoulder bone, the shoulder bone's connected to the up. And at the end of the day, it is. And you cannot treat a patient like they are an elbow, right? You have to think, I mean, there are muscles and tendons and bones and nerves that are, originating in the neck, traveling through the shoulder, the arm, crossing the elbow joint, and then all the way down, into the hand. And you have to think about how the complex biomechanics of this and how certain restrictions, like you said, in the shoulder are going to cause overload down, at the elbow, and how maybe certain weaknesses that maybe originate from a pinched nerve in the spine may also do the same thing. So you have to think about the patient as a person and as a whole person. And that's the starting point, I think, no matter what. And then, as it relates to a lot of times the places where people get pain here and here are where the muscles and tendons originate that actually are responsible. Their primary action is for flexion and extension of the wrist, as well as kind of the digits, and pronation and supination, which is kind of this movement here of the hand. And so they originate up here. This is where the pain is. This is where the problem is. But the function of those muscles is really down, kind of in the hand and wrist. And so limiting these types of movements with things like neutral wrist splints, particularly at night. I mean, you can control plenty during your day-to-day, but when you fall asleep at night, who knows, things are getting pinched and right, and so, using a neutral wrist splint at night that's not allowing you to get into this position that's pulling on, one way or the other, and potentially it just lets the area rest as you are resting. And so that's why the neutral wrist splint, or, just a slight touch of extension in some cases is useful for people. As it relates to the counterforce braces or the bands that people will use up here, what I usually tell people is if it helps, use it. One piece that I'm always kind of thinking about and trying to educate and mention is, especially for the lateral elbow, the outside of the elbow, which is more common. There's a small subset of people, maybe 5-10%, that actually get irritation of that nerve. It's called radial tunnel syndrome, that can kind of go along with tennis elbow or lateral epicondylosis. And in those cases, the nerve gets irritated, right where kind of those muscles are, and where the chronic kind of degenerative changes are. And so putting a counterforce brace on in those patients can sometimes actually worsen the pain that they feel down into the wrist. And so what I tell people is give it a shot. You can try that during the day when you're doing maybe some activities that are provocative that you can't avoid, if you're at the computer, whatever, to try to distribute forces more evenly across those muscle tendon units, so that the ECRB or whichever specific portion of the tendon that is usually the most affected, you can decrease the force through that specific one and potentially decrease pain. But if it's making your pain worse, you may be one of those people, those 5 to 10% that actually has irritation of that nerve, which is not a motor or a sensory nerve, so you don't get any kind of those changes. It's purely it's a pain sensation. And so if the counterforce brace is making your pain worse, I say stop using it. You may be one of those people. But otherwise, I think it's fine to try it. And the risk benefit makes a lot of sense, I think. Does that answer your question? I know there were probably 10 more.
No, it does. I think that's great. I think as a PT, I'm always hesitant to, if people say I've got this brace, usually they come in wearing it, Haylee.
Yeah.
So, you know, if it's not, you know, that's fine. I usually recommend, if they're in acute phase, you know, I'll recommend a gentle wrist extension splint,
Absolutely.
just to shut things down for 2 weeks. You know, recommend some non-steroidal anti-inflammatory for 10 to
Yes.
14 days. You know, and then I'll work on the root cause, right? We'll look at the posture, we'll look at everything else. But let's talk about like the interventions, right? So,
Yes.
you know, we talked about PRP a little bit. We talked about Shockwave. You know, Shockwave is not fun. I know it hurts, you know, at the ankle, you know, trying to set, you know, not necessarily sell it, but when I send patients to bend, you know, I do the dry needling.
Yeah.
That itself hurts enough, you know, with the E-stem through it. So I can't even imagine, you know.
Oh, do you put the E-stem through it? Nice. Okay.
But yeah, so let's talk about the different options
Let's talk.
that people have.
So I think along the same lines of dry needling are trigger point injections. So whereas the dry needling, you know, it uses a needle that doesn't, you know, it does not have a hole in the middle, so you don't like inject through those type of needles, right? And usually it's a slightly smaller needle than what I would use for, say, a trigger point injection. But really, you're kind of trying to accomplish the same thing. You're going for those trigger points, which are basically tight bands within the muscle that are painful for patients and are contributing to that muscle being kind of in a shortened state, like you were touching on earlier. And so the thought process behind it is, you know, if we can use a needle, either a dry needle or a trigger point injection, to help you know, create a mechanical twitch response, get that muscle to lengthen. And in some cases, actually, you know, there are decreased inflammatory markers within inside the muscle. You know, there's some basic science stuff supporting its use, though not a ton of high level evidence. But really, you know, in my experience, it can help people a lot. And so along the same lines as the dry needling, sometimes I'll do trigger point injections in clinic, which the only difference, like I was getting at, is that it's a slightly bigger needle because I'm going to do an injection along with it. And I'm injecting a local anesthetic, usually just a little bit of lidocaine, with the thought being that you can sustain it can stabilize the muscle membrane a little bit better. So you're not necessarily using it to numb, though certainly it has that effect in the short term, but it can kind of stabilize the muscle membrane in that lengthened position to have more sustained effect, basically, is the thought process there. So that is the least invasive injection option that I use in clinic. And I pair that a lot, you know, with ongoing physical therapy. A lot of times, you know, like I said, I have good working relationships with, you know, most of the physical therapists I work with. And so they'll shoot me a message, or the patient will, or, you know, they'll mention that they think they could benefit maybe from a little bit of trigger point or dry needling. And so I'll go after, you know, either it's the, you know, the flexor pronator muscles on the inside, or the extensor supinator muscles on the outside, again, to try to help lengthen the muscle there. And so super safe, just office-based, you know, maybe a little bit of soreness afterward, but pretty much everyone is a candidate, you know, for that. There, you know, unless you had an infection in the skin right over the area, there's not a lot of, you know, contraindications for that necessarily. And then moving on from there, in terms of other interventional stuff I think about, you know, a lot of times people come in wanting a steroid shot, wanting a cortisone shot, because they're in so much pain.
Can we stop there for a second too?
Yes.
So people come in all the time saying, why do you think that is? Like, they're self-diagnosed, like, I need a cortisone. Is it because they talk to their friend? Like, why? That's like the number one thing.
I think it's just that is what people know, you know, people have heard of cortisone shots. They've had family and friends get them, and they do fine. And so it's more familiar, I think. And when we start talking about these other things that are a little less familiar, it's like anything else, right? There's a pause. There's a little bit of a hesitancy with something that you're not quite as comfortable with. And cortisone shots, just, you know, within society is language that everyone knows. Most people know or recognize. So I think that's why. And they just, you know, like I said, they're in so much pain, they want a quick fix. And it is overwhelming to get all of this information and, you know that they have probably, you know, at least 4 to 6 to 8 weeks of physical therapy ahead of them, or strengthening and home exercise program, to really get to where they want to be. And so, you know, we all want that. We all want the magic bullet. And I think that's what, maybe it shouldn't have that reputation, but it does. And so I'm having that conversation a lot too.
Yeah.
The only time I think about doing a steroid shot is usually if I either confirm with ultrasound evaluation or with MRI that there's not a significant partial tear in the tendon. Because again, I touched on this a little bit earlier, but my worry is that I put steroid in there, which we know transiently has a weakening effect on the tissues. So my worry is that I do that injection, which one is not going to be in the long term, is not going to do any good. It would be a very short-term thing, because there's tons of evidence that for long-term, greater than 1 to 3 months, there is no improvement after a steroid injection compared to, say, a physical therapy program, and plus or minus some of these other interventions that we offer that may actually boost effect. And so if I were to do a one-time steroid injection, it's when I know that the tendon itself isn't about to tear, or is less likely to tear as a result of the steroid in the area. And I do it with ultrasound guidance. So when I do the injection, I make sure that I am not in the tendon, because injecting the steroid into the tendon further increases the risk that you could have a partial tear or rupture. So really, I use that to ensure that I am outside of the tendon, and kind of bathing the area rather than injecting the tendon itself, which is extremely hard to do if you don't have kind of ultrasound guidance. So that is how I use my steroids. I use my steroids sparingly in the area, and it's always a conversation about risks, benefits with the patient. And I think certain patient considerations, like you were talking about earlier, beyond steroid, a lot of times there are out-of-pocket costs, and that is not accessible to everyone here in the United States. It's just how it is, and it's ethically, I hate that. I hate that that I can't offer, that not every patient has the same accessibility to all of these treatment options. But certainly that comes into play, because a lot of what we're going to talk about from here on out, there are potentially out-of-pocket costs to patients. And the other thing too is if someone comes in and they have like a wedding, they want to be able to like dance at their kid's wedding, or they have a big trip of a lifetime, some big event. Maybe I'm a bit of a softie, but I'd be a little more likely to use something that I know is going to be a short term, just a Band-Aid, to let them enjoy those events. So that's how I feel about steroid.
I think you have to consider those things. So for instance, we've got a PGA, somebody who plays in the PGA, and he's got an issue, he needs to play this weekend.
Exactly.
You're going to treat that player different than you're going to treat somebody else, right?
Yes.
So I think that's just to get through the bind, like get through a weekend, and that might be a cortisone prescription, right?
Yeah.
Cortisone, whatever. But that's different. There's different frames. Every patient is different. Let's talk about, just a little bit before we dive into the PRP and the Shockwave and the out-of-pocket, and how frustrating it is that you can't just go right. You want to go right there, but then you say
yes.
$500 a pop or whatever it is.
Yeah.
That can be a difficult conversation, right? But
yes.
let's talk about, again, just diving into the tissue changes and sort of how there's a difference between a tendinopathy at the musculotendinous junction and the teno-osseous junction, and just kind of talk to people about that and, how that affects, because you're doing ultrasound, obviously diagnostically. How do those conversations play out in your office, and how does that affect your treatment?
Yeah, I would say more often than not, it's kind of at the, when there are kind of partial tears in the tendons and things like that, it's usually kind of, more on the undersurface of the tendon, and it's usually closer, kind of right at the enthesis, or, right where the tendon is kind of beginning to insert there into the bone. More common there than it is at kind of the muscle tendon junction, though. You have to think about it as a whole unit, and that's why we sometimes combine these interventions using trigger points to target the muscle and lengthen that, as well as then thinking about how we can target the tendon, the chronic degenerative changes in the tendon as well. So I think you have to think about both, and I think that helps to explain why we do combine, a lot of these treatments. Is that what you were asking?
Yeah, because I think you might you might think twice about, of course, if that like tenoosseous structure is
Yes.
really about to go, you're
Yeah.
not sniffing a cortisone shot. But
Right.
the musculotennis junction, if it's a little bit iffy,
Yeah.
probably gonna hit that area with the cortisone.
Right. Exactly. Greater healing potential and greater blood supply usually in that area, which is why I think the tears less commonly occur there even in the first place.
Yeah, no, that's great. So let's dive into the fun stuff, the PRP and the shockwave.
Yeah, it's fun for me, but it might not be fun for the patient.
So let's talk about why.
Yeah, sure. So out-of-pocket cost is one thing that is not fun. So PRP, first of all, taking a step back, platelet-rich plasma. Basically, what that is you show up to my office about a half an hour early. There's a blood draw that occurs ahead of time, and that blood goes into a centrifuge, which spins the blood really, really fast, concentrates the platelet layer. We draw that platelet layer only, avoiding other types of cells because the platelets are rich in growth factors. And that is what we inject. So we literally are injecting your own medicine when we do platelet-rich plasma. And with that in mind, there are some, contraindications and maybe some patients that wouldn't be, good candidates for platelet-rich plasma. So those that maybe have pre-existing platelet disorders, low platelets, other medical conditions that can result in low platelets, we might expect that we might not get as much of a benefit from one of those types of injections. Certain patients that are on medications that affect the platelets, even anti-inflammatory, normal NSAIDs, right? I want patients to be off of those for at least 7 to 10 days before I do a platelet injection, because there's evidence in the literature that it affects the quality of the platelets and the concentrations of the growth factors. And I want as much, as much of that as I can get to maximize the potential benefit of the injection. And then there's other things to consider, like, you are injecting concentrated growth factors in an area, which may, including things like VEGF, vascular endothelial growth factor. And, there's a strong role of that, say, in certain types of cancer. And so patients that have active cancers are usually not candidates for platelet-rich plasma because, again, we just don't want to do anything that could potentially, make a patient worse, really, at the end of the day. And there's no real solid evidence one way or another. Some providers, especially if it's kind of a blood-based cancer, won't, even if you're in remission, they want you to, you would want to be in remission for years, probably, at least a year for maybe more aggressive providers, or even longer, depending on what the type of cancer is and, the risk for recurrence. And so that's certainly something to think about with PRP and some of the other orthobiologic injections. That's always, it's part of our standard, things that we would look at from a medical perspective to decide if people are eligible or not, amongst, some other things. But so that's kind of the gist of PRP. And then, Shockwave is not an injection, so it's less invasive. You don't break the skin, with Shockwave. You're not putting a needle anywhere. You are using a mini jackhammer, is how I describe it, to try to accomplish similar things to the PRP. So with the PRP, you're injecting those platelets that are concentrated in growth factors. You're trying to reinitiate a healing cascade. You're drawing healing cells to the area. You are sending signals to help those cells proliferate or increase in numbers. And then, eventually that's going to lead, hopefully, to a healing process, and then eventually remodeling as kind of the last stage. And with the Shockwave, you're trying to do a similar thing, but with extracorporeal, so outside of the body shockwaves, right? And so you're trying to potentially disrupt some of that abnormal blood, the like we were talking about earlier, the abnormal blood vessels or nerves that can kind of start to creep into the area in these chronic conditions, as well as bring kind of good blood flow to the area, and again, kind of help that cell signaling cascade in terms of restarting a healing process in the area. And so, like you were getting at, it's not, there's multiple types of shockwave. There's radial and there's focused shockwave. And, it's kind of, I'm happy to get into the weeds about it, but it is a little, kind of more provider specific, and really kind of making those individualized treatment plans in terms of when you would use one versus the other versus combined, and those similar kind of contraindications that I was mentioning before, some of those don't exist with Shockwave. So someone might be a better candidate for Shockwave than they would be for, say, an orthobiologic or a PRP type injection. But as you can see, I mean, it becomes very nuanced in terms of decision making. And additionally, there's the research piece, and that's always something that I'm talking to patients about, and I'm talking to other providers about, because there is good evidence, especially the lateral elbow, for the use of platelet-rich plasma. So I'm talking about level 1 randomized controlled trials, where they're comparing platelet-rich plasma to a placebo or a, more gold standard type treatment, and finding improvements, at that, usually at the 3 to 6 month time frame. So it's not like steroid, where we expect you to get some pain relief in days to, a week or two for peak effect. This is months, it's, I usually make you a little worse before I make you better, because I'm trying to restart a healing cascade, and that first phase is a little bit inflammatory, and so usually in terms of the benefit that you're trying to see, counseling is key here. You're likely going to see benefit at probably 6 weeks on the earlier side of things. Up to really, 3 months is, I think, when consistently I start to see, really good results, but even sometimes a little longer than that. And so certainly then, there's the conversation of what, well, would this have just gotten better on its own in that amount of time? Right.
So that's the toughest sell, right? So when you're talking about something that costs, I don't know what a PRP or Shockwave is usually, what, $100 a visit or something like that?
More than that. All of these are a little bit more, at least, in kind of the, system that I'm practicing in. The Shockwave is a little cheaper usually than the platelet-rich plasma, but they're both in the like $600 to like $1,000 to $1,200 range. So this is not, it's a pretty penny, and there's no guarantees.
Yeah, and then the Shockwave is probably more than one treatment. You do
yes,
3. Yeah,
exactly. It's usually combined in, say, like a 3 to 5, treatment plan, and everyone is different. Whether they charge. So maybe that was what you were getting at. Whether they charge per session, or like the price that I was giving is usually, a combined package. So a little cheaper usually. For the Shockwave, but multiple visits as opposed to the PRP, which is one visit, but more expensive. And in terms of timeline for improvement, I mean, I think they're pretty similar. You might have some earlier initial improvements with the Shockwave due to desensitization in the area that are temporary, but kind of the long-term healing cascade is the same, right, for both of them.
Yeah, I mean, what a tough sell though, because that's, it takes 3 to 6 months to get better. And usually when people come into our offices, they want pain relief now. And I think that's probably why they're demanding the cortisone shots. Yep. They want the wet needles, they want the lidocaine, and they want, either PT or something that's, obviously nobody comes in probably to your office wanting to do twice a week of PT, but we both know that that's the cure, right? Over time, that's the strength is the key, right? But to get over that hurdle of pain, right? Why they came to see in the first place. I think it's important for people to know that it's a long game when it comes to these interventions. Yeah. Now, do you ever stack the therapeutics? Will you ever do like a lidocaine injection and then do like the Shockwave, or is that?
No, actually, that's how it used to be done to make it a little bit more comfortable, even for the patient. In a lot of different areas, sometimes they do local lidocaine injections versus nerve blocks to just make the procedure more comfortable. And more comfortable, I mean, people do fine. It's painful, maybe like a 6. You want it to be a little bit painful, during the procedure, so that you're transmitting enough force through there to really, initiate that healing cascade. So maybe you're aiming for like a 6 or a 7 out of 10 during the procedure, and then that goes away very quickly afterwards. So short-term pain for long-term gain is what I say. And yeah, so in the past, people, physicians and other providers who perform this procedure would pair it with some sort of anesthetic, and they actually found worse outcomes without it. Some of the thought process being that if you are affecting those small nerves in the area and maybe central pain processing, that it is useful for patients to actually feel kind of that desensitization and pain in the area. If that's one of the ways that this is working, is through kind of a central mediated pain effect. So we don't use that anymore. And actually the same goes for PRP, in that when the platelets are exposed to lidocaine or whatever other local anesthetic that you're using, it can actually kind of decrease their efficacy. And so what I do is I numb patients up as much as I can, right up to kind of the point where I want the platelets to go, whether that's inside of the joint or inside of, if there's a partial tear in the tendon, say, with more of the elbow focus. And so I'll numb them up as best as I can, but right where I'm putting the platelets, I don't want anything else there. I don't want numbing medicine to decrease the quality or the response of the platelets. And I also want volume-wise, I want to be able to get as much of the platelet in there as opposed to just, taking up some of that space with the numbing medicine.
That's great. And I think that's, you're talking to the healing points too, like how the tendons actually heal. And I think 90% of what I see is the tendinopathy, the tendinosis. And I think because that's the most frustrating thing to treat. Would you agree?
Yeah, I would. And for patients too,
And when there's that neogenesis of nervous tissue, right? So and what we're talking about, for people who don't know the words that we're using, is nervous tissue literally builds around the infarct, wherever the pain is happening, and it's sending pain signals to your brain. So what I asked Haylee was, can you add an analgesic to make the symptoms less? And what she's saying is that when you do that, it's blocking that kind of communication with the spine, so that we actually want the nerve roots to be exposed so we can hit them and make sure that they can actually heal, and not be continuing to, that positive feedback cycle of the substance P to your brain. We don't want that.
Yeah.
So let's talk about, we've talked about tennis elbow for now. I feel like we talked for another hour.
I know. Where did the time go?
So complicated though, isn't it? It can be so difficult to treat. When are you referring to a surgeon?
Yeah, usually when I kind of hit the end of the road, whatever that is for the patient, and it is different for everyone. So even as it relates to my surgical colleagues, there are some who feel that this is a non-operative condition. They do not do these, they do not operate or do debridements or, anything on this diagnosis. And then there are many, many others that do, and feel that, it can help those patients with refractory symptoms that just aren't responding to conservative care, that just are not able to tolerate it due to, the amount of pain that they have. And no matter what I do, I can't get them over that hump, so to speak, where they can really make progress with an eccentric strengthening program. And so, I don't have a solid answer for you. It differs for everyone, but certainly I'm trying a comprehensive conservative treatment program, plus or minus, some of these lesser invasive injections, or, depending on what the patient wants and what their desires are, and, everything else, maybe maybe Shockwave, maybe PRP, other orthobiologic considerations. And then, at any point when a patient gets fed up, I offer them, a consultation with my surgical colleagues at any point. Even early on is fine. Talking to a surgeon is not signing up for surgery. And so, I appreciate their expertise, and sometimes like having that conversation for the patient is really what they need. And they'll come back and say, yeah, no, I don't want to have surgery. Or they'll say, yeah, I feel like that was a good fit, and I'm done with this. I'm gonna do this. But you have to understand that there's a rehabilitation, process post-operatively too. Right. And so it doesn't eliminate, some of the work that you have to put in. And so, yeah, it varies.
what are you looking at? What are you seeing for outcomes, surgery versus non-op?
I mean, I would say that the vast majority of patients are able to avoid surgery. Vast, probably 90+% of patients. When you think about 1 to 3% of the population being affected by, this condition on an annual basis, and the number that actually have surgery for it, it's the vast majority do not. This is a non-operative condition. But I would say that for those that do end up having surgery, the outcomes are generally very good. And I think part of that depends on your surgeon and, how you set the expectations. It's all about expectation setting, I think. And that's why it's nice to know and work closely with my surgical colleagues, because, I can counsel the patient ahead of time about, what to expect and, how the conversation is going to be and what the approach is going to be like, and a little bit about the postoperative rehab and things like that. So they can go into the conversation a little bit more prepared and really kind of hone in on the questions that are important to them.
Yeah, and I think that's super important, Haylee, just to juxtapose to the non-op options, right? So I think when people understand that it's still going to be 3 to 6 months to recover from an elbow surgery, and that's what they're looking at for what we're doing, non-operatively. I think that's really, you have to put both side by side so people can make an educated choice.
Absolutely. At the end of the day, I think that's both, any medical provider's job is to just give the patient information so they can make the best decision for them, right? And so I think the more information, the better to a certain extent, as long as, it's like, there's a lot of misinformation available out there on the internet, but if you have a provider that you trust and someone who knows their stuff, then all I try to do is just let people make the best decisions for themselves.
Yeah, and then it's rapport, right? And it's kind of building 100%. That trust. I think when you know your patient well enough, you know which route they're supposed to go. I think that, and people need that. I think a lot of times, and I'll just use my wife went to, obviously she's pregnant. She went to the OB, and there were a couple different options for something. And she's like, well, you're the OB, tell me what to do.
Yeah.
Right. I mean, you should know me well enough after doing your subjective screen as to what you think I should do. And I think that there's definitely a role for that, but you also want to have the options, right? You want to know what else is out there so that you don't feel like you haven't been exposed to your options too. I think that's huge.
Agreed.
I can't believe we're coming up on an hour here. That's crazy. I don't know what you're like for time.
We could. Do you have a few more? We have a few more minutes if you want to. Yeah. I know you have some controversial topics here.
I think we're going to talk about Tommy John. I mean, controversy, spinal manips, all that good stuff.
I know we have so many great things to still.
So I read research, and they exposed the Spinal Manipulation Institute. So I'm certified with dry needling and the spinal manips, and even through MGH with my orthopedic residency, there's research that if you manip a thoracic spine, you're immediately reducing pain scores in lateral epicondyle and in the knee, which is incredible. And I think it's just the role in the sympathetic nervous system response. Yeah. Can you talk a little bit? I don't even know if that's kind of along your purview, but can you talk a little bit about the sympathetic responses and that sort of thing?
I would say, some of my DO colleagues have a little bit more experience in OMM or osteopathic manipulation techniques, and so probably would be better, able to speak to that than myself. For at least in my mind, I think about, again, the kinetic chain and how restrictions, even if they're restrictions in the trunk, even if it is like in the thoracic area, which is not directly connected to the elbow, obviously, but certainly if you think about, say, a pitcher on the mound and the forces that are having to be generated up through the entire, through the legs, through the hips, through the entire trunk, and then ultimately to the elbow. I think that in that way, in that biomechanics sense way, it kind of can make sense to me, where you're improving movements and biomechanics in other areas that are having, positive effects downstream or upstream. But beyond that, it's a little bit outside of my area of expertise. What I generally tell people, and this relates to kind of chiropractic care, osteopathic manipulation, other manipulative techniques, acupuncture, if it's helping, I am all for it, And whatever kind of a patient kind of wants to, avenue a patient wants to explore, I think it's worthwhile. If it helps, great. If it doesn't, then you've tried it. And it's probably not something to continue on, especially if it's always just, a very short term kind of improvement. But certainly on the front end of things, if it's helping you especially tolerate the physical therapy piece or return to sport or things like that, I think it's useful.
That's great. Let's talk about young female athletes, gymnasts, dancers, cheerleading, elbow, shoulder, wrist pain. How are you managing those athletes different?
Yeah, it's tough. It can be a tough patient population to manage, especially if they get to the point where, they have developed some, stress injuries in the elbows or osteochondral defects, things like that. It's tough. And really, what you want to do is prevent that from ever happening in the first place, if you can, because once you have it, it's hard to manage. And, to your point, so it's these athletes that weight bear, through their upper extremities and maybe have a component or are at higher risk for hypermobility or generalized laxity, that are putting even more force in an abnormal way through the joints and through certain areas of the bone. And so really at the end of the day, it's the prevention piece. Like I said, if you can, and the same thing goes for UCLs and, like all of these, what are overuse injuries, usually for these athletes, if you can prevent the overuse in the first place, then you're going to be in a much better spot. I think that a lot of times, for whatever reason, there's a lot of sports are fun and they're competitive, right? And you want to win, and parents want to win, and coaches want to win, and everyone wants to win. And it's easy to kind of get wrapped up in that and think that, maybe earlier sports specialization or, winning one specific tournament or something like that is going to have potential long-term benefit, either for collegiate sport or whatever, kind of beyond, and kind of get wrapped up in that. But really, at the end of the day, what's going to have the best overall impact on the athlete and allow them to compete at the highest level for the longest period of time is injury prevention. Certainly there are instances where there's maybe a college recruiter present and, it's a little bit of a unique scenario, but for the most part, at the end of the day, avoiding early sport specialization, I think, is key. There was a recent article that was published that looked at collegiate athletes, and I think less than 20%, less than a fifth, reported early sports specialization before the age of 15. So if you can diversify, the sports that these young and adolescent athletes are playing, number one, it prevents athlete burnout, which is getting more and more attention and is so important to consider from both a mental health and a performance perspective. Burnt out athletes do not perform as well as athletes who are not burned out. So diversifying the sport participation helps prevent burnout, but then also helps prevent overuse injuries. You're allowing, it makes sense, right? You're giving the tissue a break, and you're also using other muscles to, if you're, say you're a runner, right? And all you do is run long distance. Your so that your glutes, your core, they're not strong. And if you can incorporate some lateral sport, maybe you play soccer for a little bit, or maybe you lift weights and focus on that in the off season, or do some plyometrics, or you're going to improve your performance in your main sport, and you're going to prevent injury. So I kind of got on a tangent. I feel so passionate about this, but yeah, it's just the prevention piece that is so key, because once you have an athlete who weight bears through their upper extremity and has joint hypermobility or laxity, you're in a tight spot because it's really hard to offload the bone, and you can't necessarily tighten up those soft tissues, right? That's just how they are. Over many decades, the laxity will probably improve, but not over the short course, over the short term. And so yeah, it's just, and then it falls back onto kind of the, relative rest, strengthening up, the whole kinetic chain, making sure you can offload the joint as much as you can, giving bone time to heal. A lot of those same principles that, apply to everything.
Yeah, and it's funny. It's I think Lyle McCaley wrote an article probably a decade ago now, but it was James Andrews.
Yeah.
And he talked about taking one season off a year, right?
Yes.
Like you would think that that's the craziest thing in the world for a 3-letter, a 3-star athlete or whatever.
Yeah.
But you just have to. I mean,
Yeah.
that's what I tell every parent comes in with. The next Pele or the next like all-star gymnast, in soccer, I see it in soccer, gymnastics, dance too. But really the specialization starts at like 5 or 6 years old in soccer.
Oh,
and I try to, Haley, say to these parents, like, it's great. The skill piece is really important, but
it is.
if they're not playing different sports, they're never getting exposed to, to different environments and, their lateral chain, just like you were saying, posterior chain, lateral chain, different sports stress different things. And I think
absolutely
that's an education. If, anybody takes anything out of this interview, that's a huge piece for, and plus, and I love the stat that only 20% of college athletes before the age of 15 play only one sport. Right.
Yeah. Right.
That's what you mean by sports specialization, I think, right?
Mm-hmm. Yeah, exactly.
So,
where you focus on one sport, you play it. I think the definition is like more than 8 or 9 months out of the year, you're playing that one sport. Baseball, I mean, there's tons of year-round leagues,
And 2 or 3 teams at the same time.
Exactly. Especially over the summer months. And that, that brings me back to the elbow a little bit and UCL and kind of the throwing injuries and things like that, where the, avoiding early sport specialization is key, allowing recovery days off, seasons, months off is so important. But then in the season, really having accountability for your own, for the athlete themselves when they get to a certain age, and the parents and the coaches when they're younger than that and all the way through, but really having accountability as it relates to these overuse issues and respecting pitch counts and making sure they're actually keeping track of them, and maybe delaying the throwing the breaking balls, and though that there's more evidence lately that the velocity actually correlates more to UCL than even the type of pitch. So there are all these things to take into consideration, and I think just trying to just because I don't know, I still think that the most important thing in allowing a kid to reach their full athletic potential is keeping them healthy. And that means injury prevention and avoiding overuse injuries for the most part. So yeah, I mean, I could talk about this for another hour.
I mean, but it's just such an important point to parents who are listening, is that your child can still excel at a sport, because especially as they hit their teenage years, they're starting to develop motor pathways that are brand new, right? They're new, and their skill set, they're going to be able to expand their skill set anyways. Yeah. So allow your kid to be a kid. Allow your children to play and experiment with different sports.
Yeah.
They don't have to play
and
soccer.
Fail. Maybe they have a sport that they're not quite as good at, but they love. And that's so great to mix in, and builds a lot of other different types of qualities. Thinking about mixing up team sports versus individual sports. If you have a kid that's a runner or a swimmer, or whatever, maybe getting them, in the off season into a team sport, which has been shown in, some studies to really facilitate even improved, social support, mental health, because they have that more of a built-in community, just trying to switch it up and trying to have fun with it. It's, if the child is, talented enough, and certainly there's a luck component and many other factors that come into play, but for the most part, if they're going to be able to play at that high level, they're going to be able to do that regardless of whether they played all year or if they played for a season. And so just like you said, remembering their kids and to have fun and to take the pressure off, for certain seasons and periods of time, I think is just so important.
Yeah, that's great. I feel like we should have a whole different podcast on it's like sports related youth injuries. I spent an hour on epicondylgia.
I know. Oh my gosh.
I didn't think I could talk for 30 minutes about epicondylgia, but
yeah.
It was funny. But anything else you wanted to touch on? So how can people get in contact with you if they have anything?
Yeah.
You treat everything. You don't just treat the elbow.
Yeah, right. I know. I primarily practice. I'm at Spalding and I'm at Mass General. I primarily spend my time in the Mass General Sports Medicine Clinic here at main campus, or not at MGH West in Waltham a couple days a week as well. So I migrate a little bit, and it's the same number. You can Google it. It's just the Mass General Sports Medicine Center, and I have a lot of awesome colleagues too. Like I said, just in a multidisciplinary team. So, I think that for anyone that's just hoping to get more information or better insight, second opinion, just run kind of their thoughts, on treatment plan by someone, want more of, kind of an evidence-based treatment plan or something like that, anything like that, come see me, come see one of my colleagues. I mean, I think we're pretty nice. I think that in general, we really try to, take really good care of people. So.
Well, I think through this phone call, I think anybody who listens knows that you care about people and you put the patient first, and that there's not just you, but you have a whole team around you to support, a salubrious outcome, which is great. So, Haylee, thanks again for joining me today. And
thank you so much for having me, Sean. It's been really fun.
Yeah, sorry for keeping you an extra 15 minutes.
Don't worry. It was a great conversation. So thank you again.
Yeah, thanks so much for your time, and have a wonderful weekend.
You too. Happy Friday.
Happy Friday.